I'm Fabiola Mann, a fifth-year medical student, and I'm going to be talking to you about Guillain-Barré Syndrome. Okay, so first of all, Guillain-Barré is autoimmune destruction of peripheral nerves. So this is basically where the body attacks its own nerves tissue. There's 3 types. The most common one is acute inflammatory demyelinating polyneuropathy, or AIDP. This involves segmental demyelination, so basically patches of myelin sheath will get destroyed. The other types are acute motor axonal neuropathy and acute motor and sensory axonal neuropathy. And this is where the actual axon is getting attacked as well, not just the myelin sheath. So normally Guillain-Barré follows a respiratory or gastrointestinal infection. So it's quite common for patients to say that a few weeks before they started noticing the GBS symptoms, they had a bit of diarrhea or they had a bit of a cold. Now this can be either viral or bacterial, and some common culprits here can be Campylobacter and cytomegalovirus, as well as others such as EBV. Another variant of Guillain-Barré, and sometimes considered another category altogether, is Miller-Fisher syndrome. Now, I'm not going to go into much detail on Miller-Fisher other than saying that it normally presents with a trio of ataxia, ophthalmoplegia, and areflexia. Okay, so let's talk about a case. So we see patient X, let's say he's a 30-year-old male, and for the past week or so he's noticed pins and needles in his feet, and they're just feeling a bit weird, really. And a few days after he first noticed symptoms, his legs started just feeling a bit sore and weak altogether, to the point where it's getting a bit difficult to stand and walk normally. On examination, you notice diminished reflexes in his lower limbs. While taking a history, he mentions that about 2 weeks ago he had some diarrhea, but it did clear up, so he didn't think it was a big deal. So normal GBS presentation. We have rising symmetrical weakness. Now, it can present slightly differently in everybody, and it is possible to have one limb being more severely affected than the other, but usually both will be affected, and this is quite an important clue that there's symmetrical involvement. You might also notice that it doesn't rise perfectly. You could have pins and needles in your feet, and then suddenly more proximal muscles, such as muscles around the thighs, get weak quickly. One of the big clues here is also that it's rapid onset. So it just sort of comes out of nowhere in patients which don't really seem to have any other risk factor other than they had some sort of cold or some sort of stomach bug a few weeks before. Quite a common symptom is dysesthesia as well. So basically, it's where when touched, the skin kind of responds with a fairly unpleasant, abnormal feelings. In this case, when we say dysesthesia, we're mainly talking about tingling or pins and needles. The patient might also experience some paresthesia. Most cases, around 70%, also experience areflexia. And about half of the patients present with pretty severe pain somewhere along their legs or sometimes in their back. Now, as the disease progresses, the cranial nerves can get involved, and this can present in all sorts of problems, especially around the face, mouth and throat. The patients may have a facial droop, which mimics Bell's palsy. They might also notice some double vision, difficulty speaking and swallowing. There might also be cardiac and respiratory symptoms, bradycardia, tachycardia, hyper or hypotension, and some difficulty breathing. Unfortunately, in places where a ventilator isn't available, it's possible that this will be the cause of death. There's simply no way to help the patient breathe. GBS can also affect urinary retention. It can cause more or less sweating than usual, and it can also affect the bowel. Basically, it completely depends on the patient. But one of the general kind of rules is that it starts with weakness or numbness or tingling or pain in the extremities that kind of slowly rises and moves towards the trunk. Okay, so back to patient X. So it's looking like this is probably a case of GBS, but what happens next? So when we're diagnosing GBS, there's 2 main areas we're focusing on: the nerves and a lumbar puncture. So with regards to the nerves, we usually use an electromyography or an EMG. So this is where small needles are placed inside the muscle to record activity when nerves around the area are activated. And the second one is nerve conduction studies. So this is basically when you give your patient small electric shocks, and then you can measure how quickly the nerves conduct or deal with the electricity. These sorts of tests can actually give you a pretty vital clue as to whether the actual axons are damaged or just the myelin sheath, so you can get a sort of clue as to which type of GBS you're dealing with here. So in a lumbar puncture, a sort of typical response for a patient who has GBS will be a normal cell count but a raised protein. So we're talking about more than 400 milligrams per litre. So the most common and readily available treatment for GBS is intravenous immunoglobulins from donated blood. So it's thought that these somehow block some of the autoantibodies, although we're not 100% sure of the mechanism. Another treatment is plasmapheresis or plasma exchange. So this is basically where you filter the patient's own blood to try and get rid of some of the autoantibodies, and so there's slightly less markers for the body to attack itself. Then, and arguably most importantly, we have supportive therapies, such as ventilators, feeding tubes, catheters, painkillers, etc. As I mentioned earlier, one of the very common causes of death is that the patient simply cannot breathe alone. So if we are able to use a ventilator, this can help massively. So the prognosis can vary quite a lot between patients. Usually from the start of symptoms, the peak of symptoms, it's about 12 days, but this can vary up to a month. And the total time for recovery can vary from weeks to a whole year. Although some studies have suggested a mean time of around 200 days, because even after the GBS has sort of stopped, the body needs time to heal the myelin sheaths that have been destroyed or attacked. Just under 15% experience some type of long-term disability. Death occurs in less than 5%, although it should be noted that this is a lot rarer in areas where an ICU is available. And unfortunately, around 3% will suffer a relapse at some point in their life. Let's do some questions. So first of all, how common is areflexia on presentation in patients with GBS? So the answer is 70%. Question 2. What is not a category of GBS? So the answer is acute sensory axonal neuropathy. So here we have the basic summary, what GBS is, how we will diagnose and treat it. And I hope this was useful. Please subscribe.